right, there you go. Hi, everybody. It looks like everybody's joining, so we'll start in just a minute while we wait for everybody to get in. I see the numbers ticking up, so that's good. Hi, everyone, and welcome. We will begin in just a moment. I see more people are still entering, and so we want to wait till everybody's logged in, and then we'll get started. All right, let's go ahead and get started. Hello and welcome, everyone. Thank you for joining us today. Today we will be talking about Hawaii's Our Care, Our Choice Act. My name is Samantha. I'm the Hawaii State Director for Compassion and Choices, and with me is Caryn Ireland, our medical outreach consultant. And we also have with us today Senator Roz Baker, who was the sponsor of the Our Care, Our Choice Act. And we've invited Senator Baker here today because we've lost a very special friend and champion for the Our Care, Our Choice Act. Many of you know John Radcliffe. He was an incredible man who was advocating and fighting until the very end for the people of Hawaii and for the issues he believed in. And so we wanted to take a moment here today to remember him. And so we've asked Senator Baker to join us. She was a good longtime friend of John's. So Senator Baker, I'll hand it over to you.
Okay, thank you. And thanks for including me and paying tribute to John. I've known John since the 60s. We were both at the National Education Association advocating for teachers. He was in the field organizing, as he often did, in touch with folks that needed his help, and I was doing government relations. So we kind of came to Hawaii and still ended up doing some of the same things. But I remember John as somebody who really wanted people to be empowered. He worked for the Hawaii State Teachers Association for, I think he's still the longest serving executive director. He beat me to Hawaii by a few years and helped me get involved in politics. And then he went on to work with university professors, helping J.N. Musto, his longtime friend, to organize and make sure that the professors got their contract and their working conditions in the most advantageous way for them to do their jobs throughout the university system. I'll always remember John's smile. He was an excellent organizer, as I said, and an advocate. And I really think that if it hadn't been for his network and his advocacy, that we would not have been able to pass Our Care, Our Choice. He was instrumental because we lost it one year, as I recall, very few votes, and it had to come through my committee. And I remember our hearing room being filled with a lot of antis, and John was able to get the proponents in there as well, and we were able to move it forward. So I will always remember his smile. I will always remember how important he was to so many organizations to get their issues heard. And he had a way of bringing people together so you could find that common ground and get measures passed. So he just, we've lost a really a really effective advocate. I've lost a very good friend. And the comforting thing to know is that he's left a lasting legacy, not only for this issue, but for education and others. And I'm hoping that if his wife, Diane, and daughter, Rami, approve, that when we reintroduce the bill, we can name it in his honor.
Thank you so much, Senator Baker. I think that's a great idea. And, you know, it strikes a chord in me to think that when John was diagnosed with his terminal cancer, you know, there's a lot of ways he could have spent his time, and he chose to work his tail off to pass the Our Care, Our Choice Act. And it's incredible to me, you know, that he was able to use the law. So on Tuesday night, he was able to take his medical aid in dying, surrounded by family and friends, and go on his terms in the way he wanted, in the way he fought so hard for himself and for the people of Hawaii. It's an incredible, beautiful, poetic thing, and a legacy.
Yes.
You know, I think most of us want to change the world for the better, and it's very clear that he did.
Yes, he went out on his own terms, and I think, you know, he had that dignity at the end that so many of us long for, and some are able to achieve it and others cannot for whatever reason. But yes, and this is a perfect picture that you have up with the beautiful parts of Manoa in the background and on his balcony, and with that great smile.
Thank you, Senator Baker. Well, I guess with that, we'll dedicate today's webinar to John, and, you know, I think dedicate the law as much as we can to John. It really is his legacy, and you know, he wanted to advocate until the very end. In June, we sent out an action item to our volunteers, and he was the first one to reply. He wanted to help, and I couldn't believe it. You know, he was the first one, like, okay, Sam, what do I need to do? And we're like, John, you don't, you know, we could have other volunteers do this. You don't need to do this. But he never quit, and it's just an incredible spirit.
Yes. Yes. So that's why we need to continue on to make the law a little bit easier for people to act, to utilize it. We need to do, I think Hawaii's law is one of there are more hoops. It's a little bit stricter than some others. And we have a lot of experience now from other places. So I think we don't need to be, people don't need to be as scared of this measure as I think they were when it was first passed. So yes, I look forward to working with you and Senator Rhodes and others to make sure that we can make some tweaks and improvements in our statute in John's honor.
Thank you, Senator Baker. Thank you so much, and for all the work that you do. We appreciate you. Well, I know John would want us to keep working just like he did.
Yes.
And so thank you to everybody who joined us today. We really tried to invite people who didn't know about the law. So I'm hoping there's a lot of people on here who didn't even know this law existed. And in fact, our very first, we're going to do a little poll question just to see where everybody's at, how familiar people are when we get started. But first, I did want to let everybody know that you can ask a question at any time. At the end of the webinar, we are going to answer questions live. So, but again, at any time you can type your question. There should be a box on your screen. If you really can't find it, you can always email us, and we'll look through that so that we can answer everybody's questions. I also wanted to let you know that we are recording this webinar, but don't worry, we can't see you. So if you didn't brush your hair, nobody knows. But we are recording it so that people who weren't able to make it today can watch it later. So we're the nonprofit Compassion and Choices. We're most well known for working to pass and implement medical aid in dying laws. We have our roots back to Oregon's law, which has been around for over 20 years. And, but our mission actually is to empower everyone to chart their end of life journey. So if they want the option of medical aid in dying and they're eligible, then we want to make sure that they can access that option, as well as the whole range of end-of-life options. And we will touch on a few other end-of-life options today. So let's get back to that poll question. How familiar are you with medical aid in dying? So if everybody can take a minute, you can answer on here how familiar you are. Okay, it looks like we have 71% have voted. I don't know if everybody's going to vote, but that's okay. You're anonymous, we won't know. Okay, it looks like it slowed down, so I think everybody's done voting. So let's share the results. So 40% of you are very familiar, 51% are somewhat familiar, and 9% are not at all familiar. So that's a great range, and hopefully we can answer everybody's questions and help everyone today. All righty. So question time. We usually do a little icebreaker, and today's a little different because I think we're all thinking about John and, you know, what the power of his legacy. But I do want to ask everybody, you know, how many of you here today on this webinar are going to die? Anybody? Are you going to die? I know you're probably an American, so you may not. Death is a really hard topic for a lot of people. It can be really hard to talk about. It's often the elephant in the room. You know, we don't want to think about it. But the good news is that talking about death won't hurt you. It's not going to jinx you and, you know, make you magically susceptible to death. But it will help you plan for your end of life so that you can have a good end of life experience. So I'd like you all to think about how you would like to die. You know, just imagine your perfect death. You know, how do you envision the way that you would die? And I think we have another poll question for that. So if you want to respond, again, it's anonymous. You know, how would you like to have your end of life experience be? So at home with loved ones, and you can answer more than one. So at home with loved ones, with pain and discomfort managed, in a hospital or facility, or other. I'm watching people are voting. And again, you can choose more than one. All right, I think it looks like it slowed down, so we can share those results. So 76% said at home with loved ones, 84% said with pain and discomfort managed, 8% said in a hospital or facility, and 6% said other. And that's pretty normal. I'm not surprised to see these results. The interesting thing is that, you know, while the majority of people say that they would like to die at home with loved ones, most people tend to die at a hospital, you know, often with machines and not always even with family members. So again, that's why it's really important that you're here today so you can learn about your end of life options and how to make sure you have the end of life that you want. So with that, I am going to hand it over to Caryn to talk about end of life options.
Thanks, Sam. These results aren't a surprise. And I think the other thing that's interesting about the hospital and facility answer is that our hospitals and now hospices and palliative care are really offering people another option too. But all of those, being at home with loved ones, having our pain and discomfort managed, I think are important to everybody. But we did want to go through the various end of life options so that we remember there's a big picture around end of life. Pursuing life-sustaining treatment is often the first one that people might be confronted with, using ventilators, tubes, CPR. That's a lot of what is actually linked when people are doing their advanced care directive. You'll see those kinds of questions. How much life-sustaining treatment do you want? And being able to have that conversation with your family and friends. Refusing treatment is always an option. Discontinuing treatment is an option. As I mentioned, hospice and palliative care continue to grow in their support with end-of-life care. Some hospices have inpatient or in-hospice facilities. Some have resources that come to the home. Palliative care and supportive care are really expanding here in Hawaii. So we have lots of those. Lots of these options are now starting to cross over. So it's not just an either or opportunity for people. Voluntary stopping eating and drinking and continuous deep sedation have been around for a long time, obviously. Continuous deep sedation is when really the end of life is really managed by medications, and the person then is sleeping pretty much throughout the entire last days, maybe weeks of their life. And then medical aid in dying, and that's really what we're here to talk about today. Next slide.
Thank you, Caryn. And I did want to mention too, not everybody's familiar with voluntary stopping eating and drinking, and we do offer webinars on that specific end of life option. So if you're interested in that, please let us know and we're happy to provide that. But I love this picture. This is such a beautiful picture. You can see John there with Senator Baker and the legislature and Governor Ige signing the Our Care, Our Choice Act in April of 2018. That's when the bill was signed, and it went into effect on January 1st, 2019. And in fact, John Radcliffe was the very first person in Hawaii to request the option of medical aid in dying. There are now 9 states and Washington, D.C. all have the option of medical aid in dying. In fact, in 2019, 3 states had laws go into effect. Hawaii started it off, then New Jersey in August, and Maine in September. You can see here the light blue states all have authorized medical aid in dying. The dark blue states all have legislation, and we are really gearing up for 2021. We're hoping to pass a lot of medical aid in dying laws. In fact, Massachusetts has a bill that's moving and hopefully will go through this year. The yellow boxes show where we have active compassion and choices volunteers. So if you have friends or families in other states who want to get involved, let us know and we are happy to plug them in. So what is medical aid in dying, Caryn?
So as we mentioned earlier, medical aid in dying is one of many end-of-life options, but it's good for us to step back and really just take a look at what our definition here in Hawaii is. It's a medical practice that provides an eligible, terminally ill, mentally capable adult with a prognosis of 6 months or less to live, with the option for medication that they can decide to self-ingest peacefully at the end of their lives. There's a couple of key terms here that we'll be talking about in the future as well, but it's important to remember this is self-ingest. This is the person is doing this, and that our law is really built around a number of these components in this definition. Mentally capable, terminally ill. And we really want to always remember that that's really what this law was all about, is to help people that have this diagnosis now, prognosis of 6 months or less to live.
Thank you, Caryn. Other provisions of the law that are really important: wills, contracts, insurance, and annuity policies are not affected. In fact, the underlying illness is what is listed on the death certificate, and that's really important. Medical aid in dying is not the same as suicide or assisted suicide. Suicide is a very different thing than a terminally ill person who chooses to take medical aid in dying. A person who wants medical aid in dying doesn't want to die. They want to live, but they've been robbed of that choice because of their terminal illness.
So why do people request medical aid in dying? It really is for a number of these reasons. And as Sam said, it's really related to the fact that they now are, this illness, this disease, this cancer is taking their life. But people request, one, because of loss of autonomy, losing that independence, that ability for self-care. Some people may request medical aid in dying because of their fear of pain and suffering, and realizing that those last days, months may be very, very difficult. Some people will request medical aid in dying because of loss of dignity. What are the things that are happening to their body that they feel like they're losing their dignity and who they are, and diminished quality of life. But as we take a look at all of those, it's probably not just one of those. So it's not for any one particular reason, but rather the totality of what's happening to a person's body at the end of life. And that's really where we're finding that this type of opportunity, this type of ability to make this decision around medical aid in dying is so important. We also know by looking at, this has been researched now throughout a number of states, the Journal of Medical Ethics also concluded, though, that there's no evidence of or heightened risk of the elderly or women or uninsured being forced into or looked at as the population for this. That doesn't occur. People in low economic status or educational status, or people with particular psychiatric illnesses, which is part of why we have that mental health assessment as a part of our law. So it's really important to remember that this is all about a person who is losing autonomy, fear of suffering and pain, diminished quality of life, and making this decision for how they want their death to occur.
Yeah, in fact, medical aid in dying has been around for over 20 years. It started with Oregon's law, and there hasn't been a single incident of coercion or abuse in any of those 20 years in any of the states that have authorized medical aid in dying. The only problems we hear about the law are people who have a tough time getting through it, which we'll talk about later. But one interesting statistic that we see again and again from all of the authorized states is that about a third of the patients who go through the whole process to get their prescription for medical aid in dying never actually use it. But just having it on hand gives them a huge sense of relief to know that they have that option. I'll never forget meeting a man on the Big Island who told me he never felt more alive than the moment he received his medical aid in dying. He was terminally ill and he was so afraid of what his last weeks and days would be like. And he told me he hopes he never has to use it. And he said, I know it sounds crazy that I've never felt more alive than when I got my prescription, but it gave him a new lease on life to know that he wouldn't have to suffer if he didn't want to, that he had the medication there if he needed it. So how do you become eligible for medical aid in dying? Well, you need to be an adult. You need to be a resident of Hawaii. You have to be terminally ill with a prognosis of 6 months or less to live. You need to be mentally capable of making informed medical decisions, and you have to be able to self-ingest the medication yourself. So if you meet all of those requirements, you can ask your doctor for a prescription and pick it up the next day. I'm just kidding. I'm kidding. It's very complicated. It's a 12+ step process, but I say it that way because a lot of people think it's that easy, that it's not, they can wait until their suffering becomes unbearable and then request the prescription. And so a lot of people are really upset when they realize they may not be able to access the option because there is such a long process involved in order to be able to access the medication. So what are the steps that you need to go through in order to access medical aid in dying? And like I said, it's a 12+ step process. So we're going to give you the cliff notes on it, and we will send you a follow-up email with a lot more information, but these are really the steps that a terminally ill person needs to go through in order to access the law.
Okay, so I spend a lot of time in my history working with doctors, a lot on the quality side and helping run a clinic. And whenever we start talking about the doctor and the patient relationship, Sam knows that I'll pop in with what's it like on the doctor side as well as the patient side. So I think that these steps really help both parties that are part of this huge decision. So now we're talking about how important it is to talk with your doctor, to ask your doctor if you've received a diagnosis of a terminal illness. It's time to talk to your doctor. Now, in a couple more slides, I'm going to say it's probably time to talk to our doctors now. But certainly when we start to see that we're towards the end of our life and we've had that diagnosis, it's very important. Your doctor is who you need to be spending time with. Ask your doctor to help you with the process, and if he or she will write the prescription for you if you qualify. So as Sam said, there are 12 plus or 13, 14 steps in this process, and it does take a little bit of time. So the earlier you can have that conversation, the more that you and your doctor can be moving forward with the process. You want to make sure that your doctor writes down your requests for medical aid in dying, because there are certain timeframes that happen in this process, and it's important that that first request gets documented, because that's when the clock starts, and we're able then to be able to start to work through all the rest of the steps. Now, the other thing I would say is that you might be the first person that your doctor has had that request. And so when you're talking to your doctor, if your doctor seems unsure about medical aid in dying, Compassionate Choices is a great doc-to-doc consultation line that a physician can call, and they will be responded to by another physician who has had many years of experience with this from the mainland. He's our medical director. And this confidential phone line is for physicians to really connect with this resource and to walk through what this whole process means for the physician. What are the obligations? What are the processes? What are the steps? If your doctor does not want to honor your request, ask your doctor to refer you to somebody who will support you. Doctors know what's happening in the community. And if they aren't able, because again, maybe you're their first request that they've gotten for this, they need time too. But they also probably know another doctor who can help. And if by chance you cannot find a doctor, then definitely reach out to us. And there's a phone number and an email on this slide, and we'll make sure that that's available to you afterwards as well. But we will then as well help you try to find a physician who can help. Next slide. So once that first step is taken care of, there's a few other steps. Confirm your eligibility with a second doctor. So as a part of medical aid in dying, Our Care, Our Choice here in Hawaii, there is a consulting doctor who will meet with you and be able to walk through and look at all the requirements and what your disease state is, and confirm that truly you have a terminal diagnosis with 6 months or less to live. There's also a required mental health assessment, and that is really designed and is an important part of our law that is a part of making sure that the person has mental capacity to make this decision. Then there is another request to your original attending physician who will support you that needs to be made, and that is within separated by a minimum of 20 days. And again, these are all requirements that were built into the Our Care, Our Choice Act. And then finally, a completed written final request, which can be done before your second oral request. You can actually prepare that at any time. But what's most important is that we all start talking now. So as I mentioned, even if you're not in the state of a terminal illness, start talking to your doctor now. Ask them, if you ever were in a situation like this, would your doctor support you? And begin those conversations and share your wishes so that the doctor can start to potentially get their own background and find out what medical aid in dying would mean to them. Talk to your friends. Okay, so tonight when you go home, either with your friends or your family, and somebody says, "What'd you do today?" What are you going to say? So we would say, start the conversation. Say, "Hey, I was a part of this webinar and it was really pretty interesting, and I'm starting to think about what medical aid in dying might mean to me." Tell people that you've heard about the law, the legislation, and ask them what they think, and would they support you in your decisions. And then certainly as we talk to our family needs to know our wishes and our end of life plans so that we can all be on the same page if and when we get to that point. I guess we all will at some point, but it's more the if. Okay.
Thank you, Caryn. And I'll reiterate, talk to your doctor. You know, I'm not terminally ill. And I asked my doctor, and I actually started the conversation. I'm a runner, and I asked him, how many marathons can I run a year? So we talked about that without destroying my body. And then I asked him, if I was terminally ill with 6 months or less to live, would you support me in the option of medical aid in dying? Would you write me a prescription if I met all the qualifications? And he was like, what? no one had ever asked him about it before. And he, you know, he kind of knew what the law was, and he had to think about it. And so he did. And thankfully, he came back to me and said, you know what, if you met all the qualifications, I would support you. I would write. And it's important to say, you know, ask them if they would write the prescription, because sometimes doctors say, well, I'll support you, but they don't, you know, they wouldn't. There's a lot of responsibilities for doctors to actually write the prescription. And so I was glad, because, you know, it's hard to find a doctor when you're healthy, and it's twice as hard, or maybe even more, when you're sick to try to find a doctor. And to me, it's really important that I have a doctor who would respect my end of life wishes. And so I was glad I didn't have to spend time to find a new doctor, because that's just the kind of person I am. So, you know, it can be difficult to have those conversations, but don't be afraid. You know, it's your life and your death. And again, you know, talk to your doctor as soon as you can, and just see if they even know what the law is. So the Our Care, Our Choice Act, we have data from the first year. Between January 1st and December 31st of 2019, we know that 13 different physicians across Hawaii wrote 30 prescriptions. So 30 people made it through the 12+ step process. And of those 30 prescriptions written, 15 people did ingest their medical aid in dying medication. And it is important to remember, you know, there are people like, you know, like we know, for example, John had his prescription written in 2019 and he took the medication in 2020. So that's part of the reason that the number is much lower. But again, like I said, a lot of people go through the whole process just to have the medication, and they never actually take it. Now, Senator Baker mentioned legislation at the beginning of our webinar today. And it's really important that you understand what that legislation is and why we have it. And in fact, the Department of Health, the Hawaii Department of Health, has twice now recommended to the legislature that they amend the Our Care, Our Choice Act to make it easier for eligible patients to be able to access it. And I want to just share a quick story about Ron Meadow. This is Ron with his wife here in this picture. And Ron lived on the Big Island. He was terminally ill. He wanted the option of medical aid in dying, and his doctors wouldn't support him in it. And so he called around, tried to find a doctor, finally found a doctor who lived on the other side of the island. And unfortunately, he didn't survive the process. And Ron died in exactly the way he didn't want. And so we don't want anyone else to have to go through what Ron did. You know, in fact, even just last week, we had somebody reach out to us because their doctor said they would support them in medical aid in dying. They started the 20-day process. And when the patient went in, because you have to make 2 oral requests to your main doctor who's going to end up writing the prescription, when he went back in, the doctor said, you know what, I'm sorry, but I'm not going to support you anymore in this. And so he had to find a whole new doctor. And thankfully, we were able to help him. And that patient is being cared for. But again, it's, you know, part of the problem is, as most of you probably know, there's a growing shortage of physicians. And so one of the main amendments is to remove the barrier preventing advanced practice registered nurses from supporting their patients in the option of medical aid in dying. Now, advanced practice registered nurses with prescriptive authority already can write prescriptions for controlled substances. In fact, the only reason they can't support patients and write a prescription for them for medical aid in dying is because of the way the law was written. And in fact, you know, the Hawaii Department of Health has recommended to the legislature that we need to remove this barrier, and we need to make sure that advanced practice registered nurses who are highly educated, highly qualified, will support patients in the option of medical aid in dying. In fact, the very first physician on the Big Island to write a prescription for a patient, she's a doctor, Dr. Sharp, and she said her own PCP is an advanced practice registered nurse. She goes to an APRN. You know, they are very highly qualified, and they need to be able to support patients in this option so that people don't end up like Ron Meadow, where they can't find a provider who will support them. Also, you know, Hawaii does actually have the most stringent medical aid in dying law of all the states that have aid in dying, and it's the only state that requires a mental health assessment. And so one of the ways to make that easier would be to allow qualified advanced practice registered nurses to be able to do mental health assessments for terminally ill patients, so they don't have to struggle to find a mental health professional to perform that part of the process. We also would like to see the mandatory minimum waiting period reduced from 20 days to 15 days. So again, Hawaii is unique. It's the only state with a 20-day waiting period. Every other state has 15 days, with the exception of Montana, that, you know, their law is through a state Supreme Court decision, so they don't have a process. You know, we don't know how many people didn't make it through the law, but we have heard from Kaiser Hawaii that they had a number of patients who otherwise were eligible. They met the qualifications, but they were sick, they were dying, and they did not survive the 20-day waiting period. And so the final provision that we would like to see made is to allow the attending provider, that's the main one who writes the prescription, to have the authority to waive that mandatory minimum waiting period if the patient's unlikely to survive it. Oregon actually amended their law to have this provision because they had the same problem. Too many people were not surviving the waiting period and dying in exactly the way they didn't want. You know, in a way, it's almost worse because they thought they were going to be able to have medical aid and dying, and then they couldn't survive that minimum waiting period. So we did have legislation, Senator Baker, it was her bill, it's SB 2582. It made it through the Senate. There was a mirror bill, a twin bill that made it through 3 committees actually on the House side, but was never heard in the 4th committee. And the Senate bill had just gone over to the House side when the pandemic hit. And so unfortunately, that bill was not considered a priority bill and didn't make it through this session. But we are hoping to make these amendments in 2021, and we are going to need all the help we can get. So if you are interested in supporting this bill and helping us, you know, it's really important to make your voices heard, and we can make it as easy as possible for you to do that. So please, if you haven't already signed up to volunteer with us, we would love to have your help. So I guess I just did this slide, and I know we're starting to run short on time. We have a ton of resources on our website, and I know, you know, we really just went over the basics today, but we have a whole little packet on, you know, if you are sick or your loved one's sick and you want medical aid and dying, that it takes you through every step of the way in order to get medical aid and dying. Oops, I wanted to go back. Well, we also have an end-of-life consultation line that you can call. In fact, that patient I mentioned who reached out to us last week called our end-of-life consultation, and so thankfully we were able to help him. So again, we'll send this in a follow-up email. It's really important to us that every eligible patient in Hawaii is able to access the law. So we have our resources available in 6 different languages. If you are fluent in any of these languages and you want to volunteer with us and maybe give a presentation in one of these languages, please let us know. We would love to work with you so that we can do more education and outreach to everyone. And finally, you know, we are a nonprofit organization, and we rely on your donations. So I know this is a really tough year for everybody, but if you have the capacity and you're able to donate even just a little bit, we are so grateful for every penny that we get, and we do our best to use all of our funds to really help empower people to chart their end-of-life journey. So thank you to everyone who has donated to us, and if you were able to, we appreciate your donations. And so with that, we are going to get to questions. So I stopped sharing my screen, and our first question, it looks like it's for Caryn. Caryn, how can medical providers learn more about medical aid and dying? Is there any kind of education on medical aid and dying?
So throughout this last year and a half, we've actually been doing a number of sessions for physicians on medical aid and dying. And we have brought over the National Medical Director to make sure that we could offer continuing medical education seminars. We've done them now on all islands, all the major islands. So Kauai, the Big Island, Maui, and obviously Oahu. We are very able to do these via webinar now. So if you have a physician organization that would like to do a session like this with maybe more of a clinical flair to it, we certainly can do that. So Dr. Grube is usually our main presenter. We add now our local physicians so that we can make sure we've got our own experience built into this. Dr. Grube also talks about the medications that are a part of the whole process for the physician so that everybody's on the the same page about what works and how things work, and then the real clinical components. So if you are interested in further clinical education, please send a note to Compassionate Choices. They'll get it to me. That's part of my job, is to help set all those things up.
Thank you. All right, another question. How has COVID affected medical aid in dying? That's a really great question. So you do have to have a terminal illness with a prognosis of 6 months or less to live to access the law, and that's almost never the case with COVID-19. It's very difficult to get that prognosis of 6 months or less to live, and then also, you know, have the time frame to get through the process. So it's not really a viable option for COVID-19, but again, this is a brand new virus, and you know, I don't know what will happen down the line. I will say though that we have a really great toolkit on our website that lets people know about COVID-19, because a lot of people don't realize that you know, to be intubated, what that's really like, to have CPR, what that's really like. You know, it's not like the movies. Usually they break your ribs if you need CPR. If you're intubated and you survive, which is, there's a very low survival rate, and they take it out, it can be very traumatizing and difficult. And so we really encourage everybody to be educated on all of their options and possibilities with COVID-19. So again, we have that on our website, and we can send that in a follow-up email. The next question is for Caryn. What types of medical providers are able to prescribe medical aid in dying medication? MD, APRN, PA? And I know we kind of talked about this, but maybe you can reiterate it.
Right now it's MDs, physicians. We are hoping to add APRNs with the changes or additions to the law next year. So any physician would be able to write that prescription. But again, that's one of many steps in the whole medical aid in dying process. There is also a great resource for physicians on the Department of Health website, which walks through all of the components. But it could be a specialist, it could be a primary care physician. But right now, the requirement is that they are a physician, not an APRN or a PA.
Thank you, Caryn. Another question, this is for you, Caryn. Is tissue and/or organ donation an option after someone takes medical aid in dying medication? And I can help with this if you're, yeah, go ahead.
Yeah, yes, it is. In fact, we recently had that situation happen where a person told us about their plan to use medical aid in dying, and then they also donated their organs. Because this is a medication that is used in other ways, and it doesn't do anything that destroys organs and things like that. Probably what would have destroyed the organs was the disease. So that's the only thing that would be the issue. Anything else, Sam?
Caryn. I think the next one's for me. But so our next question is, how can I volunteer for Compassionate Choices here in Hawaii? I love that question. Great question. I think our volunteer manager may have asked it. Stephen Jameson is our volunteer manager, who many of you may know. And we love our volunteers. There's a lot of different volunteer work you can do. So if you don't want to give a presentation, that's fine. There's other things that you can do. We're always looking for people to help with making phone calls, as well as, you know, writing letters to the editor. There's a whole range of activities you can do as a volunteer. So if you would like to volunteer for Compassionate Choices, again, you can go to our website. I think on the top of the homepage, it says Take Action, and you can click on Volunteer, and then we'll get your name and information. And, you know, you can also just reply to Christina's email about RSVPing for this, and we'll get you plugged in. Let's see, the next question is for Caryn. As it stands now, which providers do the mental health assessment, and how does that work? Are there standard assessments, or is it at the discretion of each provider? Do they write a letter to the primary doctor to confirm the mental capacity?
So the mental health capacity assessment can be done by a psychiatrist, a psychologist, a licensed clinical social worker. And usually what we have, it's been great. We've connected up with the Hawaii Psychological Association. They actually can connect with the physician and get them to the right resource to provide that assessment. Now, correct me if I'm wrong, Sam, but this mental health assessment can be done via telemedicine. And by the way, many of the components can be done via telemedicine now as well. And they are doing their typical mental health evaluation for mental capacity to make decisions. Go ahead.
Sorry.
No,
I didn't mean to interrupt you. I was just going to say, I'm really glad you brought that up because I meant to include that in my answer for COVID-19. Telemedicine, you know, Hawaii has done such a great job with telemedicine. And in fact, most of the big healthcare systems do allow for all of the consultations for medical aid in dying to be done via telemedicine right now, which is huge because when you're terminally ill, the last place you want to go is to a medical facility where you might pick up COVID-19. So, you know, again, if you or your loved one is terminally ill and you want the option of medical aid in dying, ask your doctor if you can use telemedicine so that you don't have to physically go in. And, you know, even when there isn't COVID-19, it can be really difficult to physically go in for all of the doctor's visits. So I really applaud Hawaii for the great work they've done around telemedicine.
You know, there's one other thing about that, Sam, is a number of the large healthcare organizations have some natural ability to connect physicians and mental health professionals as well. So one is to go through the Hawaii Psychological Association, but your healthcare organization may be able to make that connection as well. We're seeing the role of nurse navigators really bubble up to help with all the various components of medical aid in dying now, and they are really great to help connect all the dots for the physician and for the patient.
Yeah, and I'm going to give a shout out to Hawaii Pacific Health and Kaiser. They've really, really gone above and beyond to make sure their patients are supported and are able to have patient-directed care. All right, next question. Is there a link to the actual statute? Ooh, it sounds like a nerd like me. I'm familiar with the Oregon and Washington statutes and taught about the laws to nursing students. That's great. I'm relatively new to Hawaii and would like to read the legal language. That's such a great question. I believe we have it on our website, although I know we are also in the process of updating the website, but you can definitely find it on the Department of Health's webpage, the Hawaii Department of Health. They have a great section on Our Care, Our Choice Act. You can find out all kinds of information there, including an FAQ that they have. And I think you can also just Google it. It's Our Care, Our Choice Act Hawaii, or email me. I would love to talk to you. You sound like you'd be a great person to partner with.
The other thing about the Department of Health website is they also have a beautiful 2-page timeline of the entire process. And so that's another really good tool to have you as a patient and for your physician, because it really outlines all the components.
Yeah, the Hawaii Department of Health has really done a phenomenal job of implementation. All right, and I will say Hawaii's law was modeled after Oregon's law. So it is similar to Oregon's and Washington's. But again, there are a few different provisions. Some make it harder, but actually, for mental health assessment, while it is mandatory, they included licensed clinical social workers, which Oregon and Washington, I know Oregon doesn't, I'm not 100% sure about Washington. All right, do people who have chosen to end their lives with medical aid in dying sometimes change their mind at the last minute, or do people usually know when it is time to prepare to die? That's a really good question. And I think that statistic of 1/3 who go through the entire process don't ever take their medication, I think is really telling. People who want the option of medical aid in dying, it's not a willy-nilly decision. This is something they have thought long and hard about. And, when they believe it's time to take it, it's their autonomy, their decision to take the medication. So, I think I guess, I suppose in some ways that's a philosophical question, but from all the stories we've heard, all the data from all the decades that this has been around, you know, when a person takes aid in dying medication, they're sure that's their end of life option. That's the way they want to go. And, you know, if they've made it through this process, they've had to reiterate over and over and over again, orally and in writing, that they want the option of medical aid in dying. So it's, you know, again, this is not a quick decision.
But there's still no obligation that they take.
Right.
So to what Sam was saying, we find in Hawaii as well as nationally, a third of people have the medication, but they choose not to take it. It's peace of mind.
Yeah. 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 I love, there's a woman whose dad was a philosopher at UC Berkeley who was terminally ill and had medical aid in dying. He received his medication, and every day he would ask his daughters to show it to him. And he would, you know, he was a philosopher. And so he would talk about what is quality of life, like how long am I going to go? And it was very, you know, it was very philosophical for him. And he never took the medication. Every day he would, you know, his quality of life would diminish, but he was like, no, I'm not, today's not the day. Today's not the day. And it surprised him, I think, more than anyone that he ended up not ever taking the medication, but it was a huge blessing to him to have it. And his daughter's actually a big advocate for the option because it meant so much to their dad to have the medication in the home, knowing he could have that option if he needed it. Okay, I think we have a few minutes left. This is for Caryn. I want to connect and help. I'm a physician and worked with Compassion and Choices in Oregon. Welcome. I was in Ashland and I am wanting to participate. Caryn, do you want to say anything?
Sure. Send me an email or send the email to Compassion and Choices. They'll connect us up. Absolutely.
Is it possible to receive notifications when it's time to help pass bills? Yes. There's two different ways to do it. So, you know, you can sign up for our general emails, and then I actually have like I call it an inner circle list, but it's a list of people who really just want to be notified when it's time to submit testimony. And we're working on, you know, making it really easy for people to understand how to submit testimony. We actually are also doing a project right now where we're, you know, just getting ready for legislation as best we can. So, so let us know. You can volunteer, and we'll notify you when the time comes. Let's see. What if you outlive the 6-month or less requirement? Does that make the law invalid? That's another great question. So it's interesting, you know, studies show that the majority of the time, it's actually the opposite problem. A person will be told they have 6 months or less to live, and it's really 3 months or less. And there's a lot of different theories and reasons for this. However, if a person does outlive their 6-month prognosis, they do not have to go through the whole process again. Once they've qualified, as long as they maintain their eligibility, it's really up to the doctor and the healthcare system that they're at. But they shouldn't have to go through the process again. But again, you should talk to your doctor about that and just make sure that they're on the same page with you. Do you want to say anything to that, Caryn?
No, other than, well, okay, yes. Just remember, prognosis is as close of a time frame as a physician may be able to put, but it's not an exact science. So it could be 6 months and it could be 3 months, or it could be 9 months. But really, the physicians do an excellent job of really identifying, and that's what that consultation, that second job of this consulting physician can help to really look at that time frame. But it's not perfect. And yet, as Sam said, it doesn't mean that you have to go back and start all over again.
Thank you, Caryn. I don't know if I did this right, but somebody asked, can you share your email address, please? And I typed it in the box. I don't know if I did it right. I wanted to answer it live. But again, we will send a follow-up email. I can spell it out for you, but it's kind of long. It's strad, TRAD, STRAD @ compassionandchoices.org. That's my email address. And then, if you want to volunteer, you want to connect with Caryn, I can redirect your email to the right person.
I think there was one on a slide too, right? Hawaii at compassionatechoices.com.
Yeah, that's probably the one I should have shared, but I just shared you guys are welcome to email me, it's fine. I try to respond right away, but I'm not always as fast. Let's see, the next question, we have a few more minutes. The next question is for Caryn. What is hospice's role in medical aid in dying?
Oh, hospice is so important, and it has really evolved over the last 2 years, particularly in this environment, but hospice is really, I can't say enough about hospices. So each hospice is different, and each hospice has different policies. So you really want to connect with different hospices and see where they are with and where your thoughts are and things like that. But there's really 3 roles that happen and intersect with hospices. One, that their nursing staff is able to be with the patient if the patient wants through the process. So in some cases, the hospice will say, yes, their nurses can stay. Some say, no, they have to actually leave. Well, the person might ingest the medication, then come back. So there's a difference there. And the second role is, will their medical director be allowed to be the attending physician and or the third role, the consulting physician? So some hospices allow their medical director to play one of those roles. Some do not at this point in time. The hospices are evolving. It's the same thing that I have told Sam with the physicians. Some hospices are having this request for the first time. So they're having to rethink, how do we do this? I would just encourage you to talk to the hospice that you're interested in. You would probably be working with them anyway for the rest of your health care at end of life. But it's definitely a one-on-one conversation with your hospice to have them be better understanding of your needs, and then how together you can work that through.
Yeah, thank you, Caryn. And I'll just add, the hospices in Hawaii are, they're really great, and sometimes it's a hard process. For whatever reason, it can be difficult to kind of understand why a person would want medical aid in dying. So like Caryn said, talk to your hospices, talk early, and find out where they stand, and then advocate for change if they don't stand where you would like them to, or find a different hospice. I just shared in the chat box the Hawaii email. It actually goes to my email account anyway, so you can email that or my STRAD one, and we will get your email. Let's see, it looks like we have 1 minute left, and the last question, I guess, for Caryn, how long does it take to access the medication?
Once you've gone through the process, the physician will work with a pharmacist. The medication can be filled probably within a day or two. And then we have pharmacists on Big Island, Kauai, and on Oahu, all who are compounding pharmacies and are very willing to help the patients. And they go above and beyond to make that happen.
Thank you, Caryn. I'll also add, if you're a physician or your physician can't figure out where to fill the prescription, we do have a list of pharmacists that we can refer your doctor to. And there are just some really fabulous pharmacists who will help support patients in this and make sure that you get your medication. And it can also be mailed to you. So even if there's not a pharmacy on your island, there is the possibility of mailing that prescription. So I think that's a wrap. We're at 12:15, 1:15. Thank you so much, Caryn, for joining me today. Thank you, Senator Baker. It was we're so incredibly honored to have had you join us today. And I just, I'm so grateful for John Radcliffe and for everything he did. He's such an inspiration. So I hope that you all take his legacy and his life into your hearts, and just, do your best, live life to your fullest. Life is so short. So thank you for spending your time here today with us. We hope to be in touch with all of you. Thank you, everybody. Take care. Mahalo.